Hi, everyone, and welcome to the third session of the Medicaid Insights Colloquium, also known as MIC. Thank you all so much for tuning in today. I'm Sarah Gordon, and I'm an assistant professor in the Department of Health Law, Policy, and Management at the Boston University School of Public Health. I'd like to take a moment to quickly recognize the rest of the MIC Planning Committee. Their work has been vital to the success of this initiative so far. So Will Shapiro is an assistant professor in the Division of Health Policy and Economics at Weill Cornell. John McConnell is the director of the Center for Health Systems Effectiveness at OHSU, which is the hosting organization for MIC. And of course, Jamila Michener, who is also our featured speaker for today. Dr. Michener is an associate professor of government and associate dean of public engagement at the Brooks School of Public Policy at Cornell University. Her work studies the politics of poverty, race and racism, and public policy in the United States. She is the co-director of the Cornell Center for Health Equity, the co-director of the Politics of Race, Immigration, Class, and Ethnicity Initiative, or PRICE. She is the board chair of the Cornell Prison Education Program, and she is the award-winning author of the book Fragmented Democracy, Medicaid, Federalism, and Unequal Politics, which has been enormously influential in Medicaid policy research and certainly on my own work. Her work has been featured in the Washington Post, the New York Times, and the Atlantic, just to name a few. And she has been a featured speaker all over the world, including providing critical testimony about healthcare programs before the US Congress. We are so truly honored to have her share her insights with us today. So as those of us who work in research or Medicaid-focused policy already know, even under the best circumstances, legislative policy-making processes and political landscapes are complex, slow-moving, and often difficult to navigate. Dr. Michener will discuss the process of helping officials in multiple states to identify unique opportunities through administrative channels to implement changes in their Medicaid programs which affect immediate, equitable, and dignity-enhancing improvements in the lives of the individuals that these programs serve. So please join me in welcoming Dr. Michener.
Hi, everybody. Thank you so much, Sarah, for that intro. I always think intros are so hard because it's hard to hear people talking about you. It's sort of awkward, but I appreciate the intros nonetheless. I'm sharing my screen here so that everyone can see. Thank you all so much for coming and for being here. There's a lot of things you could be doing at lunchtime, so I appreciate that of all those things, this is how some of you have chosen to spend your time. And I'm looking forward to being able to hear from you at the end of the talk. Sometimes when I'm talking about Medicaid, I really focus on specifics of policy design and what the implications of those specifics of policy design may be. But today I'm going to talk about the administration of the program with an emphasis on how people experience the program based on the way that it's administered on the ground. And many people, think about this as a way of, a different way of making policy, right? Don Moynihan and Pamela Hurd have this great book called Administrative Burden, Policymaking by Other Means. And in general, we think about administrative routes as routes for potentially affecting change or certainly affecting the way that people uptake, experience, or utilize policy benefits without necessarily the force of law. And so administration is important, but I'll admit that I initially, as a graduate student and maybe for a little bit beyond then, thought that administration was just such a boring topic. I wanted to think about the policymaking process and where the real action was around enactment or design. And I just thought administration, to me, it just sounded even like a boring word. And then, of course, I started to do the work that I do around Medicaid. And I figured out by talking to people that it was the nitty gritty in terms of how they experienced the program. And that really mattered in many ways, that really mattered for their uptake and use of the Medicaid benefits. And some of that comes across, a lot of that comes across in my first book, which Sarah mentioned, Fragmented Democracy. But even at the end of writing that book, I felt like we still had a lot to learn. And of course, pandemic ensued, and we've continued to only have more and more to learn about how people are experiencing Medicaid, what the implications are, and then, of course, what there is to be done to change that and what the process of change looks like today. So I'm going to try to focus on two things today. One is I'm going to tell you about some research I've been doing in collaboration. Today, I'll focus on the research I've been doing in collaboration with folks in state government in Kentucky, and what we've been learning together about various aspects of people's experiences with Medicaid there. And so I'll talk you through that research and that process and some of the larger implications. But I'll also be, as I go, honestly, making a case. And given the room, it may not be a case that I have to make, right? It may be that I'm preaching to the choir, but I still think it's one that we have to continue to surface and highlight, and really think through in a careful way and in a concrete way. And that case is going to be that we cannot truly understand how to reform and improve and advance Medicaid, particularly with an eye towards health equity, racial equity, other kinds of equity, without incorporating in a central way the voices of Medicaid beneficiaries themselves into the processes of figuring out what the challenges are and how to move forward. Not just the administrative challenges, although I'll focus on those today. Medicaid beneficiaries also have great ideas that we can apply to policy design and to what's happening in legislative and other kinds of spaces. But today I'll focus on the administrative aspect of that, but really want to centralize the argument that there are insights that come from engaging Medicaid beneficiaries that we really can't get in any other way. Again, given the crowd, I don't think I have to say much, and so I won't spend long here on Medicaid's equity enhancing benefits. We know all of the different things that Medicaid can do and all of the different ways that it can help people. But I always think that this is an important way to start any talk that I give about Medicaid, because often I transition into talking about things that can be improved, that can be done better, or experiences that people have that are disempowering or that are negative in various ways. And I always want to be clear that the takeaway isn't that Medicaid is bad, right? And I don't know that this is the room that would take that point away, but I still think I prefer clarity over lack thereof, because we know that Medicaid is doing a lot of good in a lot of people's lives, right? And we want to maximize how much good it can do. And we also want to make sure that as it does good on one front in terms of health or these other outcomes, that it's not doing harm on others in terms of the way that people are treated and the stigmatization and other things that they can experience as they receive Medicaid benefits. And so if we want to make the most of the equity enhancing benefits of Medicaid, then we have to understand the administration of the program, and we have to be able to think through how to be continually advancing and improving on that front, right? And of course, it's really complicated. Again, this isn't the crowd that I need to emphasize that with, but from the vantage point of a beneficiary who, and especially because Medicaid beneficiaries don't spend a big chunk of their life studying the thing or trying to understand the thing or working within the apparatus, right? Instead, they're trying to navigate it so that they can get benefits that are really critical to their lives. And along the way, there are so many potential institutional points for challenge or conflict. And part of that is because of how layered and complex Medicaid is, right? Obviously, we have things going on at the national level and different kinds of regulations and dictates and such that are coming from CMS. We have things that are happening at the state level and state institutions that manage and in various ways influence the trajectory of Medicaid programs for specific beneficiaries in specific states. And then we have the managed care level, which is another set of actors, another set of institutions that come in between the beneficiaries themselves and them receiving their benefits. And then, of course, we have like the local office, right? The places where people actually go, if they're going to go to places, because we're in a world that has now experienced COVID, and many people are interacting with Medicaid primarily over the phone or primarily on the internet. And those are additional mediums and additional avenues that introduce complexities. And across all of these layers, there are tens of millions of people to be served, to be provided with and connected to benefits. And obviously, because of the public health emergency, those numbers have grown and remained throughout the pandemic. And in many ways, from my vantage point, that's great. More people getting access, more people getting the health resources that they need. But it also means that the administrative challenges and difficulties of keeping the program running have grown as well. And it underscores the importance of continuing to be attentive to that dimension of things. And of course, we know that administrative barriers are a real thing, and we have folks have done a good job of focusing on that and thinking about that. And this is a screenshot from a report from the Center on Budget and Policy Priorities, which is just an example to say it's not as though no one is thinking about administrative burdens, trying to understand what they look like, trying to fashion approaches to reducing them. And so what I think of the work that I'm going to tell you about is as a complement to these efforts, and in particular to complement these efforts by bringing in and centering the voices of the people who are experiencing the burdens and the barriers. But I also want to make sure that the emphasis isn't solely on burdens and removing them, right? Burdens are something that prevent people from being able to get what we would hope they can get from Medicaid. And so we want to reduce them, or we want to remove them altogether. But it's also important to think about the levers for change and the possibilities, right? So Medicaid isn't just a program or an institution that can introduce burdens into people's lives that we need to remove. It's a program that potentially has some levers for introducing really positive things into people's lives, and not just health insurance. And we can think about how to amplify the potential positives of Medicaid as well, how to tap into its possibilities, and not just how to stop it from being burdensome. And I think both of those things can happen through administrative routes, and both are important to keep in view, as you'll see as I continue talking today. And I've been saying this, and I'll keep saying it, and I think by the end of the talk, you'll be like, oh my goodness, we get the point. And that's fine. I actually think that's when you want to make a point and you want to do it in a way that's like so strong that it's perhaps a tad bit annoying. You do that because it's important, and because you want it to stay with people, and not just for folks to recognize, but then for us to all, as a community of people who really care deeply about Medicaid, to be thinking about what the implications are, what the next steps are. This is a quote from a woman that I talked to years ago. This was when I first started doing having lots of in-depth conversations with Medicaid beneficiaries. And so it was probably around 2012 or so. I mean, I was a few years in by then, but this was when I was really getting deeper into the qualitative work that brought me into systematic but in-depth conversations with Medicaid beneficiaries. And this was a woman I had spoken to at the time in Michigan. And she said, you know, in anything, the poor are always the one who suffer the most. But the reason why I bring this up again and again for myself, and it's a little bit of a North Star for me, something that I try to remind myself of frequently, is that this woman who I call Angie said, they don't have, she said it's most certainly true that the people who make the rules, right? They don't care. They don't have the people who make these rules and these guidelines, they don't have anyone on Medicaid. They don't have any poor people in their families. They don't care. Now, this is not true across the board. I know that I've talked to people who administer and who make rules around Medicaid, who care deeply, or who do have loved ones who are in the program. But it's important that this is the perception, because and sometimes for this is true, right? I'm just saying it's not always true. But what matters is that it's the perception, and the perception shapes the way people interact with Medicaid. It shapes the way that they're able to or not able to leverage the benefits that the program offers. And it shapes the kind of effects on them along the way, both in terms of their access to healthcare and beyond that, right? How they're treated, whether they're stigmatized, their mental and emotional health, et cetera. And so it matters that there's a sense that, the people who get to decide what happens aren't us, and they're not like us, and they probably don't interact much with or have intimate relationships with people like us. And again, I think this is probably true for the most part, but even if there are instances where it's not, it really begs the question of a voice and what it means to incorporate the voices of Medicaid beneficiaries. So this was like, back in 2012. What's been interesting over the last year and a half, as I've done a really intensive qualitative research study, which I'll describe to you in a second, with hundreds and hundreds of Medicaid beneficiaries. And one of the questions that I embedded in our interview protocol is, do you think that people like you, people on Medicaid, have a say in what happens in the program? And there are a couple questions we ask after that. There are follow-ups. I don't know that anyone has ever said yes. And we have interviewed many, many people. There's so much variation in the things that people tell us, in the ways that they describe their experience. This might be the only question in the protocol for which I think there's essentially no variation. I mean, if I come across someone as I'm coding or interviewing who says yes at some point, I guess I will have been proven wrong. But I've engaged this data pretty deeply, and this is the one question where we essentially know what we're going to get when we get there. And it's no, our voices don't get heard. No one cares to listen to what we have to say. And in fact, people are often surprised when we start asking them questions. They're like, you want to know about me and Medicaid? Why? Because the idea of someone actually engaging them in that way, in good faith, is so foreign and so unexpected. So I'm going to describe a bit about the project that I'm going to base the remainder of my comments on today. And I'm going to focus on the aspect, we call it, because we want to be sort of vague when we describe it to people and we don't want it to sound overly complicated, but we want to be clear. We call it the Social Policy Project. And depending on what state we're in, we add the state modifier. So the Kentucky Social Policy Project, the Pennsylvania Social Policy Project, North Carolina Social Policy Project. And I'll share with you today from our data in Kentucky, mostly because this is a collaborative project between me and Carolyn Barnes at Duke University, very generously funded by the Robert Wood Johnson Foundation. And it's based in 3 sites, Kentucky, North Carolina, and Pennsylvania. Happy to talk about why those sites or what we think we'll learn from those particular places if folks have any questions along those lines. Carolyn has been in charge of the operations in North Carolina and has really spearheaded that part of the project, which makes sense. She's at Duke. And I have really spearheaded our work in Kentucky. And then Carol and I are sort of splitting the difference. We're in the middle of our work in Pennsylvania right now. And so the Kentucky data is what's furthest along for me in terms of the amount of data we've collected and the analysis of that data. So I'm going to share from that. But also I've developed a really productive relationship and collaboration with several organizations in Kentucky. And I think that that's also an important thing that I want to highlight as I talk about not just the findings, but the process and some of the importance of the process. So the research was funded by the Robert Wood Johnson Foundation, and we have this 3-study state, and that's our 3-state study, and that's great. But one of the things that Carolyn Barnes and I have been really committed to is making sure that in each state we invest in partnerships with people in state governments, people in agencies that are implementing these programs to make sure that we don't just get a whole bunch of data that's useful for like publishing papers, but that we're actively working with and engaging like key stakeholders who have influence over the administration of these programs in states. And so that we can collect data that is useful to them, share that with them, not just at the end, like, hey, here are the papers we published, but all along the way. And even adjust and adapt as we go, as we're learning things, to find out more that can be helpful, directly for the work that they're doing. So in the context of Kentucky, we've been working with folks from the, and sorry, I keep moving my slides, don't know why. We've been working with folks from an advocacy organization in Kentucky called Kentucky Voices for Health. Also with some folks in Kentucky's WIC office who are in leadership of the WIC program in Kentucky. And then in general with some folks from the Cabinet of Health and Family Services. We have monthly meetings with a group of about 5 people from each of these organizations. And we worked with them to develop the interview protocol. They commented on which questions we would ask. They've helped us with recruitment. They've helped us making sure, for example, we're recruiting across the state of Kentucky so that we talk to folks who are in rural and urban areas. They've helped us when we've realized like, oh, we're getting a ton of people from certain kinds of backgrounds and not so much from others. Let's try to really think about which perspective our voices might be missing. We've worked really closely with them. We have monthly meetings and we talk through, as we were ramping up and we were recruiting and we were beginning, we talked through that process and got lots of help from them on that front. And as we've been having interviews and findings have been coming in, we've been getting the interviews transcribed and doing data analysis. And that's also been really helpful as well. And so I'll tell you a little bit about the project and or about what we're up to and what we've been doing with these folks. And then a little bit about what we've learned. But I'm going to warn you that I can barely scratch the surface of what we've learned. I mean, this is why we're meeting every month, because we're constantly learning so much. And it's information that we can then convey to people who can actually do something directly with it. Of course, there's a limit to what these folks can do, right? Because some changes can only be made legislatively. They're about policy design. But we've also been finding are significant levers that can be pulled on an administrative level, and having information about the challenges and the barriers that people are facing, or about the good things, about what's going well or what's going right, equips people who have their hands on those administrative levers with ideas and with information that is useful for actually pulling the right levers, the levers that are going to be informed by the people who will be affected by the pulling of those levers, right? Okay, so a little bit about the details. We're doing in-depth qualitative interviews. Our interviews last between 30 and 70 minutes. It really depends on how talkative people are. There are plenty of people who are just astonished that anybody wants to talk to them about Medicaid, and they have a lot to say. And then there are, of course, folks that are more reticent. We've had folks that have only had Medicaid over the last year because of the pandemic and don't have a lot of experience with the program and maybe really only have 30 minutes worth of stuff to say. But even those interviews are quite in depth. We can ask people a lot and talk to people about a lot in the course of these interviews. We're actually interviewing people, beneficiaries of 3 different programs: Medicaid, WIC, and SNAP. And the logic here is that we want to gain any comparative leverage we can gain from figuring out what could be going right in some programs. And I'll tell you a bit at the end that we've learned a lot about differences between these programs. In particular, WIC is experienced very differently for people, which makes sense. It's a different policy that's designed quite differently. But we're learning about what's working for people in WIC and being able to talk to folks who are administering Medicaid and SNAP about that to figure out, well, how much of that is transferable? Like, can you build on in your program? And how much of it is because WIC is just a different program with fewer beneficiaries and a different structure and such, but really figuring out through a kind of comparative lens how we can leverage the strengths potentially in some programs to build those strengths in others. Or even sometimes like things will be going, wrong in SNAP, and it's good for the folks who are on the Medicaid side to see what happened, so that if they're, like there's a SNAP app and there's folks in Kentucky, they have, these apps are run by different contractors that the states hire. And if something's going wrong with the app on the SNAP side, then if you're thinking about implementing that on the Medicaid side, it's useful to know and to actually do some cross fertilization so that you can learn from other folks. Even being in a meeting every month where there are folks there from WIC, SNAP, and Medicaid has been really helpful, not just from the perspective of a researcher and what I'm learning, but because otherwise these folks aren't always in the same spaces with each other and don't have opportunities to learn from each other. So this project has been an opportunity for me to learn, but then also from our partners to learn from each other. We're interviewing not just Medicaid beneficiaries, but also staff who work at the Medicaid agency. We made this decision because the emphasis on administration means it really matters who is on the front lines interacting with Medicaid, SNAP, and WIC beneficiaries. Those folks have quite a bit of say, even if we don't think about them as being particularly powerful. And in fact, some of them are beneficiaries themselves. They have a direct influence over the experiences of these of people who receive these benefits. And so we wanted their perspectives too on what the administrative process is like and some of the reasons why it might be challenging. And so we interview beneficiaries and staff, mostly beneficiaries. And I will say we're interviewing Medicaid, WIC, and SNAP beneficiaries. About 75% of the people that we interview have Medicaid. Many of them, about almost 70% have SNAP. And then WIC is a much smaller number because it's just a smaller program. And so we don't have even numbers across these categories, but we do have all of them. And the interviews really focus on people's experiences with each of these programs. We ask them about the application and enrollment process. We ask them about what it's like to stay on, right? And how that's changed for people who had Medicaid or SNAP before COVID. They notice the difference. They're like, well, I don't have to do as much anymore. We asked them about changes because we started, the interviews in North Carolina started before COVID, about a year before COVID, and so we're ongoing. So for the North Carolina data, we can really see changes in what people are saying before and after. The interviews in Kentucky started in December, that's right here, 2021, and they're ongoing. We have like 3 or 4 interviews scheduled for this week, probably more. I haven't talked to my project manager about it. And are ongoing. And so that whole time we've been interviewing folks in Kentucky has been in a pandemic context. But it's interesting because even in a pandemic context, things are changing. And we've really been able to see there's differences between what people are telling us in February and what they're telling us in March. And they'll often say something changed. We don't know what, but it's harder to do this, or it's harder to get someone. And then we'll go back and talk to the folks in the agency at our monthly meeting, and they'll say, oh yeah, there was this change. So it's really interesting being able to in real time map between what people are experiencing and what's happening on the ground. I already said that, and I already said that. This is just a little bit about who we've interviewed in Kentucky thus far. We have over 230 some odd interviews that we've done in North Carolina. We're at 146 in Kentucky. We'll be interviewing through the end of this year. We'll probably, we expect to top 200 interviews in Kentucky. And we started later in Pennsylvania. We have maybe about 60 interviews in Pennsylvania. Those are going really quickly though. So we actually expect to have about 200 in Pennsylvania by the end of this year as well. So altogether, we'll have over 600 in-depth interviews with Medicaid beneficiaries across these 3 states. It's, I want to say hundreds of thousands, but even that sounds like an underestimation of interview transcripts. It's a huge project. We have a significant research team. We have project managers. Happy to talk about the details, but I don't want to spend too much of our time on that here. But the reason for investing all this energy and effort was to really be able to talk to a wide range of people. So in Kentucky, we're talking to people all over the state, people who live in rural areas, people who live in Louisville. We have representation from nearly every county in the state in the study. We have a really wide age range. We're talking to, people who are in their early 20s all the way to their 90s. And really have just worked hard to make sure we're tapping into different recruitment mechanisms, some recruiting through paper materials, flyers put up in particular venues, sometimes through, the internet, Facebook pages, all sorts of things. We have a really varied recruitment strategy, not because we are getting a representative sample. That's not what gets achieved in a qualitative approach like this, but because we want to reach a range of people that will help us understand, to the extent possible, as full a range of the experiences possible. We had at one point a bilingual researcher on the project so that we could do interviews with folks in Spanish. That person had to move on, and we're now trying to find someone else. But we have taken every path we could take to make sure that we could get as varied a range of folks as possible so that we could get as many perspectives on these programs as possible. I'm going to share just a few of the things we're learning, mostly to give you some ideas about what we're learning, but this is really scratching the surface. I want to say that the goal here isn't necessarily around novelty. It may be that some of the things we're learning, you're like, oh, that's obvious, or, oh, I knew that. But when we talk to the state officials that we're engaging and we say, okay, here are the big picture things that we're learning, they then say, okay, that thing, can we learn more there? Like, what exactly are people saying? What exactly is happening? And then we go and we drill into the data and we can. So for example, I had a meeting last week with folks and people just kept talking about the WIC app and how great it was, but they also mentioned how some problems there were with it. And the person on the call who was representing WIC said, can we learn more about exactly what those problems are? Because we have a contractor in the state that manages that app. We can go back to that person and say, here are the things that are going wrong. And it's an outside, as opposed to expecting that contractor to, be held accountable to themselves. We are able to sort of give them some guidance about what's happening and how people are processing it. And that's just one example. We've had plenty of other examples of things that have popped up along the way where people are having a hard time reading the notices. They seem to not be able to understand them. Okay, that's something that's amenable to change. We can make those notices simpler, easier to read, so on and so forth. And so even though some of the things that we're learning aren't like, this is revolutionary, they really matter as far as thinking through concrete pathways to change in terms of administrative routes. But I always start with this because this is one of the huge things that comes out all of the time that I think is important for us who love and appreciate Medicaid. Again and again, people share about how grateful they are for the program, about how much it has done for them. And the subsequent conversation might be about some things that have gone wrong or some things that could go better. But people often, as a starting point, have harrowing experiences with health issues and find themselves, or with economic and social conditions, and find themselves essentially saved by Medicaid. And this is also something that sort of grounds and anchors me and motivates around continuing to sort of dig into understanding this program better and understanding how to make it function even more effectively for the people who are so reliant on it. It's no surprise, of course, to figure out that administrative burdens in Medicaid persist. But I think this is worth pointing out nonetheless, because I've heard quite a bit of talk around, under the PHE, the public health emergency, we've reduced administrative burdens. And I think this is true because people aren't having to recertify and because Some of the processes around the administrative piece of Medicaid have been streamlined. People have reported that things are easier, that it's easier to stay on the program, that there's less paperwork and so on and so forth. So I am not taking anything away from that. But there are a lot of burdens that don't have anything to do with enrollment or continued eligibility. And so we tend to focus on the burdens that that hamper continuous eligibility or that make enrollment difficult. And those were the ones that were sort of most acutely alleviated by the public health emergency. And people certainly felt that and noted that. Especially folks who are on Medicaid long-term who were like, oh yeah, I know the month that it changed. I mean, people would say Medicaid started being different in April, and it's like, whoa, I mean, people are paying attention and they know the details. But there's a lot of other issues that come up with Medicaid. And this is just one example. I could just have spent the rest of the talk just showing you slides like this, and that wouldn't be as fun. Things like glitches in the system that happen, right? And so now it looks like you have a different, this is a woman who talks about bringing her daughter to an urgent care for a COVID test. And when they run her Medicaid information, for some reason, the system is glitching and saying she has a different primary insurance. And as a result, Medicaid won't cover the COVID test. They expect her primary insurance to do that, but there is no primary insurance. Medicaid is the primary insurance. And so she has to call and resubmit claims and do a lot of work to get this covered. And this sometimes can discourage people from going to an urgent care or going to a provider the next time. If you're on the fence, like, should I go in or not? Knowing like, oh, I might have to go through all of this. People would say, well, I wasn't really sure I wanted to go in because I don't want to deal with the hassle. And so these burdens really matter for people being able to have access to care. And they emerge in all sorts of ways, not just around enrollment or continued eligibility. And so I try to identify for folks the other ways that burdens are emerging. We may be in a public health emergency, and some of the burdens may have been mitigated. And so why not take this time to identify where the others are and what might be able to be done to mitigate them? The other thing I'll say before moving on from this is that some of these things are just glitches or accidents that happen in the system, and they're pretty random. And you may never fully be able to reduce them. I don't know if it's possible to deliver resources to 80 million or whatever the number of people is now without glitches, without things going wrong. And one thing that's important for that reason is what the processes are for people saying that that's happening. Things like filing complaints or letting someone know that there is this glitch, right? And that is a thing that Medicaid beneficiaries often say, like, yeah, there was a problem, but I had no idea how to communicate that. And often it's because of the multi-layered complexity of Medicaid. Like, well, should I call the managed care organization? Should I call the caseworker that I interact with when I'm at the office, or the last time I called in on the phone? Who exactly is in charge of this thing? And who do I tell when something is going wrong? There are folks that are like, oh, I don't even bother with the Medicaid people. I just go tell my doctor because I know that they're more likely to listen to me, which creates burdens for doctors who then physicians who then are trying to call. And there's one woman in particular I'm thinking about who said, yeah, my doctor called the Medicaid people and worked everything out for me. And I think about how potentially suboptimal that is from the perspective of the physician. But the point is, mechanisms for letting someone somewhere know when things are going wrong are really scarce. And that means that the glitches that are almost inevitable in a program of this size and scope are going to take longer to work out and are going to make more people's lives difficult before they are worked out, if they're even worked out, right? Okay. And a little bit more on burdens, and I won't spend too long here. I say this just to say, a lot of the comments that people make about applying on the phone or calling, and this is similar to what people say about the internet, are around the challenges of doing that, right? It's if you live in a rural area, it's difficult. and when you call, if everybody's calling now, a lot of people say, well, everybody's calling now. Nobody's going into the office because of COVID. And that just makes everything harder and longer and so on and so forth. And that's expected. And that's really a function of capacity and sometimes has to do with staff capacity, which again, isn't something that is entirely determined legislatively. There's a little bit of room for managing that kind of thing. But then the other thing that I think is important is not just in terms of burdens with respect to it being hard to reach people or it being hard to get help or to inform folks about problems, but sometimes people are actively looking for sort of affirmative information. They're not just looking to tell someone there's a problem. They're looking to get some guidance, some help with something. And that can be a challenge too. This is somebody who talks about calling Humana and trying to get information about cognitive behavioral sleep therapists and getting information that was old and that wasn't really helpful. And of course, it's difficult. There are a million details and you may not be able to get someone on the phone who knows the details. But a lot of people would mention calling Medicaid to try to learn something about a resource that they needed and just not being able to Medicaid is not a source of information for people who are seeking it by and large. Burden isn't inevitable. There are people who report, for example, positive experiences. So some people talked about the phone and the switch to remote options being a positive thing. It made it easier. It was awesome, right? And one of the things we've been trying to figure out in Kentucky is this like in certain places, like are there counties that are doing a really good job of this, right? What is determining when people are having positive experiences versus when they're not? And to the extent that we can start to parse that out, we can start to get a sense of what the levers for change are. And but it begins as a first step with really talking to people and acknowledging, for example, the heterogeneity in experiences. I mentioned this before, but I want to re-emphasize it now, that information and the flow of information in Medicaid is truly a challenge. So many people talk about having a hard time figuring out what was going on, why, and therefore what to do. This is a woman who talks about the price of her medications going up, and suddenly she's paying more for her Xanax, for her pain medicine, and so on and so forth. So she goes off some of her medicine, which is probably not ideal if it's been prescribed by the doctor. And the interviewer says, well, have you ever talked to someone, this woman uses Aetna as her HMO. Have you ever talked to someone about why they're not covering these things anymore? They just said that's how they're doing it now. And I'm always too late to start to change it and everything. You can only change when they say you can. You can't just call and change. There's enrollment periods, and there's certain things you have to talk to the HMO about. There's certain things you have to talk to the Medicaid agency about. This is so complex, and there's very little guidance or information. And when people call and say, well, why? Well, what do I do now? The answer is like, well, you're too late, or it's just because it's the way it is. And it's very difficult for people to find the information that they need and to know where to find the information. Information gaps are really common, and sometimes it prevents people from taking up resources that they might otherwise take up. This is a woman I spoke to, or we asked, like, is there any information you get from Medicaid that's helpful? And it's like, well, most people say, no, not really. Medicaid doesn't give information. You just apply and, you get the benefits, but they're not like helping you figure anything out or giving you any information. And she says, well, occasionally I get letters to take my child for a well checkup, which I do, but I don't really know of any extra. And she talks about taking her son to Louisville. She lives in a more rural part of Kentucky. Louisville is not nearby. Every 6 months because he has a chronic medical condition and needs to see a neurologist. So this is her very young child with a chronic medical condition who needs to see a neurologist. And she says, I heard from someone, this is like a friend, because I followed up and asked her who the someone was, that there was some kind of program you could apply for, like assistance with gas money, but we do only go once every 6 months. And I'm not sure if that program really exists, right? And with some probing, it was clear that this woman doesn't know that a transportation benefit even exists for Medicaid. And many people would mention transportation. And when probed about whether they knew that there was a transportation benefit potentially to be had with Medicaid, most people were quite surprised. Really? Medicaid will give transportation? Even people who, by my reading of the various circumstances they're in, very well may be eligible. But she says, but I never, to my knowledge, received anything from them saying, oh, hey, you can do this for your trip to Louisville. So I want to move a little quicker now, like strained bureaucratic interactions. I'm not going to spend a lot of time here. Some of this is akin to what I cover in my book, but it's really interesting to see it just come up again and again and again in Kentucky and everywhere, right? But what I wanted to point out to you about this isn't that just people are looking for empathy. They're looking to not feel like if they're judged. They're looking to feel like if they're being treated equally, and that for many people, that is not what they're finding when they engage Medicaid. But I want to point out the other side of this, right? Which is when we talk to the agency staff, they talk about why it's difficult for them to engage people in that way. Look, we have so many cases. We have 30 days. We have to do changes to existing cases. We have to take phone calls. We have to see clients. Like, it's overwhelming, right? And they admit, I feel like I'm pushing numbers, pushing papers, keying all day long, frantically trying to get it done. I don't even know who I'm helping. And so thinking about that other side, and this has opened up conversations with us with administrators, like, how are you managing the burden and the load on staff? How are you managing capacity? How are you making decisions about hiring and training? We can't answer all those questions for state officials, but we can start to point them towards thinking about the right questions if they want to address some of these issues. I'm going to end with the interview piece here, and then I have one more thing, which is to say, it was really interesting talking to folks in WIC and seeing that there are other possibilities. One thing people sometimes say to me is like, these are programs for poor people, so they're poor programs, and this is just what we're going to get from them. And there's almost this inevitability, like, oh, of course these programs are going to be terrible. Why bother trying to change them? This is baked into them. But WIC is a means-tested program, and people again and again are just like, WIC's great. They really help me, not just with WIC, but lots of other things. And they're nice along the way while they do it. And it's easy and doesn't take a lot of my time, which is interesting because WIC is actually a program that requires more from people, right? You got to see a nutritionist and you got to answer questions about what you eat. And it's not that some people didn't find that somewhat cumbersome, but for the most part, that was not the narrative that came out of it. WIC affirmatively offers people information, and it engages people in a way that they feel is much more humane and positive. It's not to say Medicaid can just wholesale adopt what WIC is doing. There's so many more Medicaid beneficiaries. It's wild. But the question remains, what can be learned by thinking about these programs comparatively? So I'm going to end here with another point emphasizing that voice matters. And these are just some ideas for how we might go from this broad idea that voice matters, which most people probably agree with, to a specific set of ways of thinking about how potentially that insight could inform choices that we're making, right? On an administrative level. Happy to talk more about some of those if folks want to. And I'll end here with this quote from Janine, a 60-year-old Black woman that I talked to in Kentucky. She says, no, we don't have a say, but I wish we did. I think we should have a say in it. I think we should matter. We still got to eat. And I love this because it just emphasizes I'm the one whose well-being is on the line. And so I do wish that what I said mattered. And part of the motivation of this 3-state study is to try to bring in a really systematic way the voices of Medicaid beneficiaries into the administrative side of the policymaking process. So I'll stop there.
Thank you so much. That was a fantastic and important conversation. We have tons of amazing questions, so I'm just going to jump right in. So the first question I'm going to share is actually from a former Medicaid director, and it is about the role of Medicaid managed care. So they were asking, are you examining the degree to which Medicaid managed care plans could potentially be exacerbating administrative hurdles, since now, we know the majority of Medicaid programs rely on managed care for delivery of health services in Medicaid, and there's a lot of variation in their features, such as utilization management, provider networks, et cetera, and then also there's variation between plans. So are you thinking about this?
Absolutely. And one of the great things about this data is so much that often we're like, what are we what are we going to pay attention to here and try to highlight. And so we'll talk to our partners and say, well, what do you really want to learn about that might help you to make some changes? And Medicaid managed care is actually an interesting potential lever, because states have some leverage for saying to managed care plans, we want you to do this differently. We want you to improve on this metric or this dimension. And so I do think Medicaid managed care plans are an important place to look. And we've paid quite a bit of attention to that. What's interesting is that so many people don't even know they're on Medicaid. Like, they're like, is Humana Medicaid? Is that Medicaid? I'm really low income and I think it's the government paying for it. Is Fidelis Medicaid? Yeah, I think it's them. But many people, when they think about Medicaid, they're actually thinking about Fidelis or WellCare or Humana or what have you. So in many ways, these managed care companies are representing the face of the government in people's lives in a really concrete way. And accountability processes vary a lot, whether and how they respond to what Medicaid beneficiaries need, and whether and how they sort of track how different changes they're making are affecting beneficiaries. All of that is very varied. So we're definitely digging into our data. For the folks in Kentucky, we do targeted snapshots. So we will pick a topic that's important to them and then focus explicitly on that through one round of analysis of the data, and pull out all of the different things that are being said, and then try to identify patterns. Then we go back to them and say, this is what we're learning about managed care. And then they're able from that to think about what levers they have, right? So absolutely, it matters a lot.
Thank you. So we have a couple questions along a similar theme, so I'm going to group them together. And it's sort of about, do you have examples or models of states that are doing a good job at elevating or incorporating Medicaid beneficiary voices? So some examples were community advisory boards or Medicaid member advisory councils, and if there are other examples even in other programs.
Yeah, I will say I have some examples that are anecdotal that I've just come across as I've talked to folks, but I actually think it's an issue that we don't have great systematic data on this. It's going to be really hard to learn how to incorporate voice if we don't know who's already doing it and how well they're doing it and so on and so forth. I think Kentucky's a great example, only because I've spent so much time with them, and not just because of this research project, which really they've invested a lot of time in trying to really grapple with beneficiaries' perspectives and implement change, but they've really invested in their their advisory capacities and other kind of institutionalized routes for incorporating Medicaid beneficiaries, and have thought carefully about some of the challenges with those institutions. If you have an advisory board that's stakeholders and 80% of the people on the advisory board are physicians or, in roles like that, and you have 2 or 3 Medicaid beneficiaries, and one of them is a middle-class parent of a disabled child whose voice matters, yes, but isn't representing the traditional Medicaid beneficiary, that gets really hard really quickly. And so folks can be like, we have an advisory board, and that can actually not mean much in terms of real input that folks are getting. So what I have been thinking about a lot, and this is something that Heidi Allen and I have brainstormed around and are hoping to go further around, is collecting systematic data about what states are doing on this front, being able to talk to states and survey them and see what is happening. The last thing I'll say is this. I gave a talk at the National Association of Medicaid Directors in, I don't know, maybe it was last November, and I focused on equity and voice. And the number of directors that came up to me afterwards and said, we're really struggling with this. How do we incorporate voice? I want to say that I might be able to give you an example or two, but this is more of a black box than it is an area that we have real knowledge of. It's one that I want to flag for everyone here that is something that we need to study more and understand better, how to incorporate voice into the institutions and processes and systems of Medicaid.
So perhaps maybe extending that line of inquiry to the research community, this is a question sort of on behalf of quantitative Medicaid policy researchers who are wondering sort of what guidance or advice would you have for making sure that beneficiary voice is not lost when we do large quantitative policy evaluation. And if there are suggestions for how researchers should go about this process of engaging enrollees and incorporating voice.
Yeah, I think that's great. I mean, some of you may know I'm a mixed methods researcher, so lots of the work I do is qualitative. And one thing I'd say quickly is you may think of yourself as a quantitative person, and you may be primarily, but that doesn't mean that you can't A, collaborate with qualitative researchers, and B, incorporate qualitative elements into your work. So if you're going to do a big, large end survey, right, you can actually talk to a focus group or two. And if you don't have those skills, bring on somebody who does at the beginning of the project to help you structure the survey questions, right? You can do something like that at the end of the project to help you figure out what doesn't make sense. I mean, my book was motivated by people, but also by the fact that when I analyzed the Fragile Family Survey, which has 5,000 plus Medicaid beneficiaries, I saw patterns that I couldn't make sense of just using the survey. And so I went and I talked to more people. And so thinking about how to sequence other methodological approaches to enrich the quantitative approach, because the quantitative approaches are valuable, really important, really compelling, but do need to be balanced with other kinds of insights from qualitative researchers and beneficiaries themselves who may be able to help you interpret that data in ways you otherwise never could.
Yeah, okay, so I'll just ask one more question because I think it sort of wraps things up and it's sort of high level. So, often when we do research on Medicaid, we think about policy implications, and so many of the improvements on the administrative side are not necessarily legislative policy or decisions around eligibility expansions. It's really about funding and capacity to hire and those resources. So in terms of approaches for advocacy, how do you target those more nebulous sort of like funding and staffing as opposed to higher level policy recommendations?
Yeah, this is great. So one thing I'll say is, even though our focus is administrative, we have a ton of things relevant to higher level policy medication or issues. So, both end, but on the administrative side, it's both hopeful that like maybe the folks that just absolutely would never move on Medicaid expansion, you might be able to move them on some other things. And so I do think folks in the advocacy space are really important here. Some of this is, and this is one of the things I've talked to with the people I'm working with in Kentucky, often they're looking for alternative narratives. And this is where the voices really matter, right? One narrative could be bloat, like we just have too many people working in this government, right? But another narrative could be inefficiency because you don't have the capacity you need to run this program as efficiently as you could. You're wasting resources, right? And you're not getting the most return on your investment in this program. And to be able to then incorporate the voices of beneficiaries to show exactly how that works and to make it real for people, the implications. This stuff is nebulous and fuzzy and doesn't necessarily feel compelling, not as compelling as like, we're going to get 400,000 more people signed up. By the way, we want that too. And so you have to really make it clear to people what the implications are. And I think that that's both the research work helps because it gives folks in the advocacy space some material they can work with for making that case. And it shapes the discourse so that we don't spend all our time on expansion and none of our time on administration. And we can sort of right that balance a bit. So anyway, sorry that we didn't get to cover more questions, everyone. I could talk with you all day.